Hello and welcome to Point of View Podcast, a series of conversations from Kaufman Hall and Associates about the challenges and opportunities now facing healthcare organizations. As the model of healthcare in this country shifts to a value-based system, hospitals and health systems must lower costs in order to meet the requirements related to care efficiency. To discuss three often overlooked ways hospitals can work towards this cost reduction goal, we sit down with Kaufman Hall's Senior Vice President, Brian Channon. Brian Channon, through the strategies that you recommend, how is reduction in cost and fulfilling the mission of the hospital something that can be accomplished together?
Well, first of all, I think I'll offer up what the sisters and religious organizations have said. So often it's become somewhat cliched. If there is no margin, there is no mission. So the achievement of operating margins is required to fund the mission, to fund the strategies of the organization. But another way of looking at it is that oftentimes programs and services functions evolve over time in organizations that are not closely aligned with the mission. And by re-examining some of those services, by surfacing those, identifying them, and drilling down into them, you can begin to identify areas in which we're perhaps overinvested, services that are not closely aligned with the achievement of the mission. If we were to trim those resources allocated to those functions, it would free up resources for services that are more closely aligned with the organization's mission.
So let's talk about some of the opportunities that you identify, often overlooked opportunities to accomplish cost reduction. Let's start by talking about reducing excess capacity. What do you see happening in hospitals today, by and large, and how can hospitals do a better job?
I think that hospitals typically don't address the impact of excess capacity. They may have a sense for our staffing levels are higher than they need to be, but don't necessarily understand what role excess capacity plays in their staffing levels and their expense levels. So I think the first thing to do is to get a sense of the role that excess capacity plays. And there's a number of analytical ways to do that. We won't get into that at a real fine level on our discussion today, but it's important to understand what the difference is between how our organization runs when we're operating at very high volumes, peak volumes in our organization, and how our organization runs on average. And to understand the difference between the peak efficiency at peak volume and our average efficiency can be sort of a gauge of sort of the built-in excess capacity that may exist in our organization. Another way of looking at that is, from a staffing perspective, is to understand how does our staff relate to our demands being placed in our department. What are our patient arrival patterns, and how does that sort of relate to how we staff and what the capacity is in those departments. And to begin to identify where the disconnects, where the gaps between what our capacity is, either in terms of physical capacity, room capacity, or staff capacity, and what the actual demands are that are being placed on the hospital, and where there are opportunities to trim that excess capacity.
What is an example of when staffing levels might not correspond with demand?
There are a number of departments where this is illustrated. The emergency department is a great example where it's very easy to analyze staff arrival patterns, the staff schedule, so to speak, against patient arrival patterns. And oftentimes we'll find a disconnect and where there's opportunities to reallocate the staffing to align much more carefully with patient arrival patterns. Same kind of thing could be looked at in the operating room, labor and delivery, imaging areas, cath lab, other procedural areas. The admitting department, when do patients present to be admitted versus what is the staff schedules to support those areas, and just identify where the gaps exist between the two can be a good way of identifying opportunities to reduce costs associated with that excess capacity.
Moving on to your second point, which is overhead costs. What should organizations be thinking about or doing to reduce these costs?
The very first thing organizations need to do is define what they mean by overhead cost. Overhead cost is in the eyes of the beholder. So we need to identify what does it mean, what are the departments in hospitals that we typically view as overhead. Is the housekeeping department overhead? Is plant operations overhead? Or by overhead, are we referring solely to administrative and financial departments? Overhead can exist also in revenue-producing departments. It's classically thought of as being associated with non-revenue producing, but there may be departments, the laboratory, the radiology department, nursing, that are clinical departments, revenue-producing departments, but departments in which the staffing levels can be heavily weighted towards overhead-level staff, such as managers, administrative staff, clerical staff. So getting a feel for what overhead means, and then beginning to identify what the factors are that are driving the overhead cost and what the level of investment is in the organization in overhead is really a first place to start in terms of identifying opportunities to reduce.
When you talk about overhead costs, you bring up the idea of shadow staff. Explain what you mean by shadow staffing.
Shadow staffing represents what some organizations may view as duplicative. They're staffing that are typically located on a decentralized basis throughout the organization, performing functions that are also provided on a centralized basis. So as an example, IT shadow staffing can represent as much as 1/3 of the total staffing expenditures associated with the IT function. Oftentimes those areas are overlooked because those shadow staffing functions are embedded in local departments, such as the operating room. So you might have IT analysts or folks playing various IT roles in the operating room that do not report to the chief information officer that may be responsible on a system-wide level for IT. So oftentimes organizations may understate significantly the true spend on overhead, in this case related to IT. It's important on a going forward basis to not only identify what our true spend is, both from a centralized as well as from a shadow staffing perspective, but to get a good feel for what's contributing to the growth of shadow staffing and how we can better rationalize which resources, which services we provide on a centralized basis versus a decentralized or shadow staffing basis.
Your final point addresses what you call a portfolio value analysis. What does this mean, and why is this important?
The idea of doing a portfolio value analysis is to do a look back at the organization and to understand how has our organization grown to the point we're at today in terms of the services we provide, the assets we own, the projects, the initiatives, the departments that we have in our hospital, and how do they contribute to the overall value of the organization. There's a number of ways of evaluating value from the perspective of how well those services are aligned with the mission of the organization, the strategies of the organization, what kind of financial performance do those services produce. Are there opportunities to better utilize the resources in other functions? Is there this notion of opportunity cost that's oftentimes not considered fully? Even looking at the projects and initiatives that are on people's plates these days. You go into organizations and everybody complains that their plates are full. Oftentimes their plates are full with projects and initiatives that may not be related very tightly to what the mission is of the organization.
What are some ways that a hospital can hardwire a portfolio value analysis into the way they do business?
There are several ways. The one way that is sort of a daily occurrence relates to how we go about evaluating positions that come up for authorization. So oftentimes an organization will have a committee that reviews the positions, and if the department is meeting its budget, the position gets authorized for replacement. What we're recommending is a means of evaluating relative importance and relative value of positions across the organizations. So we can get a gauge for is the lab assistant more important to replace than the RN position versus the director of quality management department. So you get a number of positions that are coming up for replacement. The question is, what are our priorities based upon the functions being produced by these positions and how they're best aligned with the organization's overall strategy and mission. Another thing to look at is what are the assets that we own and to what extent are they core versus non-core. So if you're looking to trim resources, one way to look at it is to trim the resources in departments, programs, assets that are not really critical or core to our operation and to our mission.
And in this way, this goes back to one of the first points we talked about, which was cost reduction strategies that you recommend aligning with fulfilling the mission of the hospital.
Correct. What we're talking about here is the notion of looking for ways to build into the organization's fabric a value analysis framework. And that should be looked at from a budgeting perspective. It should be looked at from a position authorization perspective. It should be looked at from a capital investment perspective. and from a program evaluation perspective.
That was Brian Channon, Senior Vice President at Kaufman Hall & Associates. To hear more in this series, Point of View podcast, visit us online at www.kaufmanhall.com.